One moment. Good evening, Dr. Rakesh.
Good evening, Ajit.
Yeah, so we'll just get going now.
Recording in progress.
Okay, so a very good evening to one and all. Welcome to the 45th webinar of Indian Arthroplasty Association. Uh, like the past few months, this time also, this is case-based discussions. We're trying to unearth talent from different parts of the country, particularly younger surgeons. We're giving an opportunity. So with that, I think if Dr. Rakesh wants to say something, please do, and then we'll get going with the first presenter, that's Dr. Nijith.
No, Ajit, I think nothing more to add except that we do this webinar every last Thursday of the month, or you can probably say fourth Thursday of the month. And for last couple of weeks or couple of months, we've been doing on case-based discussions. And if you go on the IA website, you'll probably see that we've reaching close to now 40 webinars. Ajit, I'm right, or we have crossed that?
45.
45. Yeah, so we've actually crossed 45 webinars. And if any of you ever need any help in presentation, you can just go and actually look at that specific webinar. Let's say if you want to talk about valgus knee, varus knees, FFDs, hyperextension, THR after, DDH or THR in, revision THRs, balancing, whatever. So all those topics have already been covered. So now we've actually moved to case-based discussions. And the next month is going to be even more interesting. And we'll have some foreign faculties also. It's going to be on shoulder, elbow, and ankle. So watch out for that space. I think it's 26th probably of September. So watch that space, and I think we can begin our webinar today.
Yeah, Dr. Nijith, please go ahead.
Yeah, good evening.
Good evening. Please share your screen. Yeah.
Yeah, good evening. Myself, Dr. Nijith Govindan from Cochin. First of all, I thank Indian Arthroplasty Association for giving me this opportunity to present in front of this august audience. So, without much ado, let's go to the case. So today I'll be presenting a total knee replacement case following a trauma in the past. So it's a complex primary total knee arthroplasty post-trauma. Coming to the case, here we have a 63-year-old female. She complains of pain and difficulty in walking since 2 years. She met with an accident in 2013 and sustained multiple injuries. Left knee, she had open periarticular fracture with multiple ligament injuries. It was basically a fracture of the medial femoral condyle, which was open, and there was multi-ligament injury, and for which she had multiple bony and ligament reconstruction procedures from elsewhere. Coming to the examination findings, she was walking with a varus thrust, and there was multiple scars on the left knee, and there was coronal deformity of around 20 degree, which was correctable. And range of motion, she has 0 to 90 degree of flexion, and clinically hip and spine was normal. This is the video showing the range of movement. She has 0 to 90 degree of flexion. Then this is the video from front. You can see there are multiple scars, especially more in the medial side, and this deformity was correctable. And this is how she was walking. You can see there is a gross deformity, varus deformity with a varus thrust. This is the X-ray showing AP showing both right and left knee. And left knee, you can see there are multiple hardwares in situ, and especially in the medial femoral condyle, you can see there are 3 screws with washer. Then there is a SS wire. Then of course there is a endo button on the femoral side, and also you can see there is a large peripheral defect on the proximal tibia. And when you take the lateral X-ray, you can see again the screws with washers and SS wire. Then there is posterior femoral and tibial defect, bony defects. So what are the challenges? So when I plan for a total knee replacement for this case, the challenges in front of me was how to address the previous scars, whether I should incorporate with the previous scars or how to approach the knee. Then of course there are hardwares in situ, so whether I should remove all the hardwares or will I be able to remove it, etc. And also how to address instability, and what is the, since the previous injury was medial, what is the status of the MCL. Then of course bone defect, there is bone defect especially in the peripheral medial posterior tibia. So how am I going to address the bone defect? And of course, what level of constraints I should use for this case. So these were the challenges in front of me when I was about to go for this surgery. So now I think let's discuss, or let's stop here and discuss on the opinion from the floor.
Yeah, but clinically, in your examination, Dr. Nijith,
Yeah.
how was the MCL?
MCL was, there was laxity, but it was like more of a, because of the defect.
Okay. So if you
Nijith, can
felt
you go
that
back
the
to your
MCL,
X-rays?
yeah,
You want
Just
to
put
see
your
the,
yeah, just put your X-rays on the screen.
yeah,
Yeah,
these are the X-rays.
right. Let's go back. Right. So I think from what you can, do you want to explain your X-ray or shall we read it for you?
Yeah, there was multiple hardwares in situ, and you can see even the posterior femoral condyle, medial femoral condyle has some lysis, and there was multiple osteophytes, and medial proximal tibia there is bone defect.
the issue is how to remove those screws. Your
That's
scars
what
are in the front, your approach will be from the front.
yeah,
So these screws are at the back. So that's the challenge.
yeah.
Not sure what that SS wire is doing there. That's
Yeah.
probably.
It was, in fact, I was not having a previous records, but from the patient statement, I think it is a fracture of the medial femoral condyle.
Yeah, I think that's obvious that this patient had a medial femoral condyle with ligament injuries. I think ACL has been reconstructed.
Yeah.
And
I think probably
damage also to the
Rakesh,
MCL.
this is probably the
Yeah,
HOFA
Ramnik.
fracture probably. I
Yeah,
think
it was a
probably this
HOFA
was
fracture,
a
yes.
HOFA fracture with an MCL avulsion.
Yeah,
That is
also
probably what
possibility
it looks
because
like.
yeah, because the screw is going from posterior towards anterior.
And you have a spiked washer there. So somebody wanted to fix the MCL, so you used the spiked washer actually.
Correct.
So that is.
So you go back to your AP view, Nijith. Yeah,
Yes,
so if you see this picture, even though the screw looked like from posterior to anterior, I have a feeling that, and your scar, if you see, is very, very medial, right?
Yeah.
So your scar is quite medial.
Yeah.
Yeah. So, and in these cases, it's always nice to have a stress X-ray also. But these are not normal cases.
Unfortunately, I don't have a full length.
It's okay, but clinical will be okay. So we'll have to rely on you. So this is the scar I was talking to you about. So your scar is very, very medial.
This was, yeah.
Yeah, but it's not outside the domain of a TKR. You can still do TKRs from this scar, right? So if you did a UKR, it's very similar to scar what you would actually have. It's a bit more medial than even a UKR, but you can do TKRs even from this scar if you have to use this. So that's your first thing. The transverse scar, which is just below the knee, you can forget about that scar.
Yeah.
But you need to get some of your hardware out, which will come into the picture.
Correct, sir.
Right. So whatever come into the picture. So when you do your cuts, This will come. The question is, what sort of implants are you planning for?
Yeah, that was another challenge. What is the level of constraints I need for this?
Yeah. So you see that your medial condyle, which is also harboring your MCL, is compromised. You also have a defect on tibia. MCL integrity is doubtful. So I think you need to have minimum VVS implant to start with, and probably also keep a hinge as a backup.
Yeah.
Because after you start cutting, you will never know where you'll end up.
Correct, sir. Correct.
So anything else you want to ask?
So that's what my main concerns are. What is the level of constraint I need to go for? Then I started with I basically do cruciate retaining. Then I plan for a PS with the backup of semi and fully constrained knee. This is what was my plan.
That sounds good.
I think that makes sense. You plan for the least. I mean, you plan for the worst, but probably you'll get away with the least constraint.
Least constraint, yeah, sir. Correct. So that's what was my plan. Then I have approached the knee through midline medial parapatellar approach, and I have incorporated the.
So let me stop you there, Dr. Nijith. Were you not worried that the space between your incision and the medial side will be a bit less, and also that there will be a lot of additions from the previous operations, that you may ultimately have to actually denude and go all the way to the previous scar anyway to actually come closer to the hardware? Did that worry you?
Yeah, of course.
Okay, so then carry on.
So then what I did was I approached the knee and I tried to remove the accessible hardwares. That was the medial. Fortunately I could remove all the hardwares on the medial side. I just left that endo button on the lateral side. So it was a bit time consuming, but of course I could do it. That medial removal of all the implants. I could go medially and posterior. Posteromedial to the femur. Then intraop MCL was intact and took a standard femoral cuts. And tibia, I took very minimal cut and minimal release. With the 10 mm poly with PS insert, I could I got a reasonably good stability. And tibial side, I put stem. So this is the intraop video. Intraop video after the original implantation. So when I got reasonably good stability with 10 mm of PS poly.
Extension. Medial lateral stable. Mid flexion. Now instability.
That's okay. I think your video is playing again and again. So you were happy on the table?
Yeah, I was happy on the table. With a 10 mm poly, I got a reasonably good stability, but I put a stem, additional stem, and I could manage the bond defect with cement and screws. This is the immediate post-op day.
Okay, I think because of so many cases, we can't be running the video all along. Get going.
This is what the post-op X-rays are. This is the immediate post-op. This is the. Just a moment, This is the post-op X-ray after the suture removal. And this is 6 months follow-up post-op X-ray. And this is the surgical scar, midline scar, which I incorporated with one of the previous scar. And this is how she is working after 6 months.
It's good.
So, I mean, you've done a very good surgery, but I think also you're lucky.
Yeah.
With a patient who had open fractures, multiple
Correct.
operations, the
Correct.
chances of infections are very high.
Yes, sir.
And you've managed quite well. So,
So
well done.
Yeah. So my take-home messages: address the skin incision judiciously. As far as possible, try to incorporate with the previous incision, or else you keep a safe distance. Then no need to remove all the existing hardwares. Whichever comes in your way, you can remove. Then as far as possible, if it is very lax, minimal bone cut and minimal soft tissue release. And consider downsizing and lateralizing the tibial tray. Depends on how you get the balance. Then be ready with different level of constraint and decide intraoperatively. So these are my...
There's a question on the chat box. Why did you have to use the stem? That's a question in the chat box.
There was a defect in the tibia, sir. There was a defect.
Okay.
So I managed with cement and screws, and there was a proximal tibia fracture also, I feel. Just you say.
While you're talking, can you unshare the screen and let Dr. Lokesh load his talk? Dr. Lokesh has joined us.
In the meantime, if anybody's got a question for Dr. Nijith, it's
sir,
okay.
I'm here, sir.
We can take it.
Please share your screen while we are discussing. Yeah. Fine. So no questions. You can carry on then.
Yeah, thank you so much.
Yeah.
Sir, good evening, sir. I'm Dr. Lokesh, I'm assistant professor in the Department of Orthopedics at Christian Medical College, Vellore. I'm presenting a 56-year-old lady who is a known case of rheumatoid for the past 30 years, presented to us with complaints of pain and stiffness in bilateral hips and knees. On examination, her hips were fixed at 10 degrees of flexion and only jog of movement was possible. And her knees were fixed in 15 degrees of flexion with no further movement, and of 5 degrees valgus on the right side and 8 degrees of valgus on the left side, and she was wheelchair bound for the past 2 years. This was her presenting hip X-ray. Stage 1, we went on to do her hips in the same sitting. We did bilateral total hip replacement, and this is her presenting knee X-rays. So considering the valgus of 8 degrees on left and 5 degrees on right, and with no further movement present and 15 degrees of flexion. On the lateral view, you can see anterior translation of tibia and patella baja. So question should be choice of implant and approach to stiff knee in 15 degrees of flexion.
Yeah. Which one are you planning to target? Both doing in a single sitting or one after the other?
One after the other, sir. We did 3 weeks later the other one.
Okay. So you're doing the left one now?
Yes, sir.
Okay. So how many of you, I mean, most of us probably would still go for a anteromedial approach. Okay. I'm not able to see the lateral view clearly because you're resting. Yeah, that's better. The left one. Doesn't look too bad. Doesn't look like too much of bone loss. Maybe how stiff was it? Was it a very stiff knee?
15 degrees, sir.
In terms of mediolateral? No, mediolateral.
No, sir. No movement at all.
Okay. So in which case, probably, you'll have to release more, and also your cuts have to be at least standard. In lax knees, you can get away with bare minimum bone cuts, but here I think you'll have to stick to your standard, maybe even go up a little bit. Many of us do take like 2 mm more on the femoral side just to get enough space there to working space. Yeah. Anything else, Dr.
So Lokesh, you want to ask?
Ramnik?
Yeah. So Lokesh, do you have a specific question to ask the panel?
Sir, considering patella baja.
Yeah, so you have a patella baja, but I think the patella is also quite stuck because it's a 15-degree flexed.
Yes, sir.
It's the patella normally which is stuck in these cases.
This is actually a very thick patella, basically. It's a very thick patella. The size, look at the size of the patella. It's like a bony ankylosis probably happening there.
Yes,
A lot
sir.
of osteophytes. So this is probably where you would actually have a look like the moment you open, it will be like a bony ankylosis. It would be where probably knock out all the osteophytes and free the patella first, free the gutters. And the moment you start freeing the gutters, start removing all the osteophytes around the patella is when you would actually start working around, and you'll have some space to look at the joint inside. If you're not able to free this patella, then you probably cannot proceed forward. The patella is the first thing which will need to be freed. And then, as Dr. Ajit said, Rakesh, I would first take
Ramnik, we can't hear you. We've
Issue
lost
with
you.
the audio.
Ramnik probably is on his
get
mobile,
some
I think.
space. It could be even a. Sorry?
We had lost you in
Not
the
able to
middle.
hear you.
Yeah.
No, no, yeah, I've just
Yeah.
logged in. Can you hear me now? No?
Yeah, now you're
Yeah,
okay.
yeah.
So basically, this is where I would say is that you take a free cut, maybe with the tibia, even a free hand, maybe take up a empirical distal cut, and you have some space to work around after you freed your patella. And once you have that, you'll be amazed. You have to basically work around, and then you can get it up. I don't think so. It would be a major challenge once you have a lateral gutter actually cleaned up. This is the challenge, would be the lateral gutter. And once you clean that lateral gutter, this should not be a problem.
Considering the osteoporosis, you need to be a little careful with your handling,
It's a known rheumatoid also.
releases. Yeah.
So probably it's like slowly keep working around. And as in hip, we say work around 360 degrees. Here you work all around the condyles, outside first, then inside. And when you keep gently releasing all the adhesions, which would be around, remove all the ACL, PCL, whatever you see there, you just remove, keep removing. I think you should be able to get some more working space. And if you have technology, then you can use navigation here. I'm not talking of robotics here. I'm just talking of simple navigation. You can help you cut the femur first, and you'll have more space, and then you can work on the tibia.
Rajkumar wants to say something.
Yeah, good evening all. Sorry for the delay. I think almost everything is covered. And to put it in a nutshell, this is a classic case of patience for the surgeon and spend some time. This one is the classical, the lateral view shows what we published in the Journal of Arthroplasty, the cup and saucer type of bone, where the femoral condyle goes and sits in the tibial condyle very nicely, and we should not try to dislocate the tibia first. So, and this is the case where you should not try to do a extension balancing first and then try to do. This is where you remove the osteophytes and then work around and get spaces, and then finally you can balance it based on the need.
Okay, you want to proceed?
Yes, sir. So we did a midline incision, median parapatellar approach. We did a quadriceps snip. The patella was orthodox to the femur, sir. So we did an osteotomy. In spite of that, we couldn't avert the patella. So we went on to do a tibial tuberosity osteotomy. Then to release the soft tissues, we have to do a femoral peel to do the ortholysis. So we did a femoral peel and then took the femur and tibia cuts, femur with 5 degrees valgus and 3 degrees external rotation. Then the tibial cut. Tibial cut, we took first 2 mm from the lateral side. It was still tight. Then we further took 3 mm and managed to use an Bushell-Papas hinged knee system, sir. And stems on both sides.
Osteotomy was fixed with what? Tibial tubercle osteotomy?
We fixed it with fiber wires.
Is that the osteotomy is too far down? For that the stem was used, or for the hinge? Okay, for the hinge.
For the hinge purpose.
But is it the length of the osteotomy always like this?
You could have used longer stems, sir.
No, the stem you have used is fine.
But
it doesn't have to be any longer.
I was mentioning
the
about
osteotomy is a long one.
The length of the tibial tubercle osteotomy is extending quite down. So now anyhow, because you have used a hinge, you have used a stem which has crossed to the osteotomy side. If hinge was not used, this osteotomy length will be a little tricky one because it would have gone little far down.
Yeah, but with the osteotomy, you don't see the implant. You still get the fit. It should be okay. When you do the osteotomy. Anyway, good. Well done. Walking comfortably.
Later, we
You've
went
done
on
the
to
other
do on
side.
the other side, sir.
Lokesh, I just want to ask
Same.
you, when we were looking at the AP view pre-op, it was looking a bit rotated. So was the actual tuberosity rotated, or it was just the knee which was externally rotated?
Knee was rotated, sir. If you can see the
The tibial
X-ray, even the
tuberosity was
foot
in
is
right
externally
place, is it?
rotated, sir.
Okay.
So Lokesh, there is a question from one of the audience that what is a femoral peel? So you want to explain that?
Sir, we released both MCL and MCL during the process of our arthrolysis, sir. We have to skeletonize the distal femur fully.
So that means you have to be prepared with the hinge.
Yes, sir.
That's mandatory in your planning. Yeah. Okay.
Sorry, I missed. How old is the patient, Rokesh?
56, sir.
56, yeah.
Okay, good.
I think Lokesh, most of your senior faculties probably would have managed with less than a hinge.
हाँ जी चाचा जी मैं जस्ट एक मीटिंग में बैठा हूँ ऑनलाइन हाँ जी ऑनलाइन कंप्यूटर पे एक मीटिंग में बैठा हूँ
So the take-home message should be in a cases like this, like called a stiff knee with a valgus or an osteoporosis, rheumatoid. The one indication for a hinge should be if you are not able to balance the flexion and extension gap. If either the flexion gap is too much or the extension gap is too much, where it requires extensive release and still not able to balance it, then that must be the reason for the hinged.
Hinge, yeah, absolutely.
Right.
So post-op, she didn't have any fixed flexion deformity, sir. She's expected to come back for her follow-up at 3 months.
Okay.
Yeah, no, this hinge will last because this is a rotating hinge and it rotates quite well. So it will last.
One quick question to everybody or to Lokesh. So quadriceps snip and TTO, can it be combined?
We first tried quadriceps snip, sir. So in spite we couldn't ever turn move, so we did a tibial tuberosity osteotomy, sir.
So that is where the the indication for a tibial tubercle
Yes.
osteotomy is very clear. If you are planning, better to plan straight away go for a tibial tubercle osteotomy.
Yeah.
Yes.
That's a good question, Rajkumar. I think we should avoid both.
Yes, that's why I asked.
Because you damage a lot of blood supply.
Can you unscreen your presentation and let Dr. Cecil share while we are discussing?
Yes.
Sequence of joint replacements in rheumatoid. Somebody's question. I think
Lokesh can
and
answer that
knees.
separately. Yeah, that's a long answer.
What is that SSIOT?
It's an Institute of Orthopedics and Trauma.
Okay.
Good evening, sir.
Is that a good hospital, Rajkumar?
Institute of Orthopedics. So directly going to the case, the patient was a 62-year-old male shopkeeper by occupation with history of fall, which he sustained at the age of 12. He was managing with the limp all these years, but for the past 2 months, patient was having severe pain, which affected his activities of daily living. And this is the X-ray at the time of presentation, sir. X-ray of bilateral pelvis with bilateral hip (AP), where we can see right hip dislocated and quite high up. On examination, the patient had 6 centimeters of true shortening. The right anterior superior iliac spine was at a higher level. Patient had a fixed adduction deformity, and the range of movements were painful. This is a lateral view. Proceeding further, CT scans were done. The coronal image showing high dislocation on the right side, and the axial cuts showing the acetabulum in comparison to the opposite normal side. The true acetabulum on the right side in comparison to the left side. So this is a 3D reconstruction of the pelvis. On the left, we are seeing the posterior aspect of the right hip, where we can see a shallow acetabulum, where the posterior wall is almost side. It's a anterior view of the pelvis 3D reconstruction, where again the acetabulum is quite shallow, and we can see the femur quite ridden up or posterior dislocation. Other cuts. So after seeing the X-ray and the CT, how to proceed further, sir? The patient had an injury 50 years back. It's a neglected posterior dislocation of the hip with a gross reduction in activities of daily living.
So any neurological deficit he has?
No, sir.
Cecil?
No, sir.
No. So it's 12 years dislocation now in a 60-year-old guy.
It's 50 years. It happened at the age of 12. He is 60
Oh, at the age of
now.
12?
Yes,
Okay.
sir. He is 50. He is 62 years now. So it has been years now.
Right. Right. So I think the principles are pretty clear, that you go in the line of like a DDH. Right. So there is no true acetabulum on top. So you got to bring it back in the original acetabulum. And you go when we do this, these are one of the few cases where we have to be prepared even in a non-DDH case to be actually doing a subtrochanteric osteotomy. So your plan would be that you would do, generally the version is not a huge issue in these cases, which is there in DDH. So version is not a huge issue, but still you would want to keep an implant which will help you with that. So generally Astrom stem is tailor-made for these sort of cases, but you can do others also like Wagner cone or something like that. But you need a subtrochanteric osteotomy. And regarding your acetabulum, the posterior wall is a bit deficit and posterior superior, I would say. So that wall is a bit deficit. So you got to be ready to use, if you can afford, I mean, if the patient can afford, with the highly porous cups now, which we have. So, yes. and they come in multi-hole also. I don't think you need kicks and screws for this one, but you need to be able to use the head to augment the posterior wall if required, or even use augments sometimes. If I go and see that the posterior superior buttress is completely destroyed, then you need actually a buttress augments. But generally, it's not going to be too difficult with a highly porous cup.
Yes, sir. So proceeding further, so these were the problems that we anticipate going ahead with the case. Soft tissue contracture, we have to protect the sciatic nerve, finding the true acetabulum and acetabular bone stock, as we discussed. Planning to do a subtrochanteric shortening osteotomy, at what level and how much we are going to do. And finally, reducing the stem into the true acetabulum.
Cecil,
yes, sir.
Just for a quick question for you. What will be the big difference between this case and a DDH in regards to your technique? Almost everything Rakesh explained. What will be the...
So here, the acetabulum is more or less little developed, sir, compared to the...
Okay.
For being it being
the most sharp contrasting feature between this and the DDH in regards to technique when doing the procedure. Were you involved in this case when the case was done?
My colleagues, I was not.
Okay, no problem. Then it's still more good that you should, if you are able to answer.
So here we plan for soft tissue release and
see that is the key thing here, because you said this is a post-traumatic long-standing problem.
Yes,
which, whereas in a DDH, if you see, you won't require any much of soft tissue or release at all. The moment you grade type 4, Crow type 4 DDH, the moment you do the subtrochanteric osteotomy, everything will fall in place.
Yes,
but this, even in spite of subtrochanteric osteotomy, I don't think that easily it will
come back
down. So you need to do a lot of release.
Yes, sir. So that's what we had planned. So we went with a posterior approach. Soft tissue release was done. The neck cut was made. Head and neck was retrieved and kept if later needed for grafting. Acetabulum we found. We confirmed it with the C-arm, the true acetabulum. Then acetabular reaming was done. A size 44, we had a proper fit. So we had placed a small size cup, a 44 size cup. Then going ahead with the femur shaft, we could not get it to the length. So we went ahead with the subtrochanteric shortening osteotomy, just distal to the trochanter.
What is the disadvantage with the 42 cup? If it was, now you
44.
have 42. If you had put 42, what is the disadvantage you have there?
High chance of dislocations, instability.
Why? Okay, 42 will...
Cecil, what would you be head size?
28, sir.
No.
You're getting 42, 28 head?
20, you'll have a 22 mm head in a
42 you'll
42
get
cup.
with,
What we
yeah.
had put 28, sir. What we had put was 28.
No, that is for 44.
44.
So the 44 cup starts with 28. But if you land on 42 or 40, then you have only 22, and 22 doesn't come with all these sizes, small, medium, long, and all. Maybe only one size will be there.
I think many companies now don't have 22.5. It's
Yeah.
becoming a bit of difficulty to find 22 heads.
Yes. So you have to be careful in getting the offset and the length.
Fine.
Right.
So we did a osteotomy, and then we had to do a 4 centimeter osteotomy, and so that we were able to reduce it to the true acetabulum. A modular stem was used in the femur. So this is an intra-op picture after the osteotomy. This is the immediate post-op picture. While passing the stem, it was about to fissure, so we had to use SSYS, encerclage, as a protective measure. And the gap was filled with the cancellous bone graft at the osteotomy site. Post-operatively, patient had 1.5 centimeter shortening on the operative side, no foot drop, knee was maintained in flexion to prevent stretch of the sciatic nerve. Initially, it was non-weight bearing for a period of 1 month, followed by partial weight bearing with ambulation with support. Physiotherapy mainly focusing on quadricep strengthening and hip abductors were started post-op. This was a 6 weeks follow-up. This was a 6-month follow-up. This patient walking at 6-month follow-up with a lurch. So the take-home message would be to do single-stage total hip arthroplasty in a case of symptomatic neglected high posterior dislocation of hip in an adult. Pre-op CT scan is essential for surgical planning. Better to keep a backup of bone grafts and all necessary implants like a small size cup, modular stems, metal augments in OT. Subtrochanteric osteotomy is definitely needed if the limb length discrepancy is more than 4 centimeter. Here it was 6 centimeter. Sciatic nerve neuropraxia is a risk in all such procedures, even though we didn't have in this case.
Cecil, I think there are 2 questions in the chat box.
Yes.
One is that how do you calculate the amount of osteotomy?
So we made the initial cut distal to the lesser trochanter. Then we pass the trial stem through the proximal fragment, and then we reduce that trial stem with the proximal fragment into the acetabular cup, and then we see the amount of bone overlap with the distal fragments. So that bone overlap is the amount of bone to be resected. And each time when we're doing osteotomy, the main thing that we have to be worried about is the rotation. So before doing an osteotomy, we take a chisel, make a mark anteriorly, so that after the osteotomy is made, we make sure that the marks match with each other to prevent malrotation.
And
I think there's
the
a
other
question on the
question,
chat box.
Yeah.
Yeah.
yeah, Ajit,
What
you
was
ask.
the second? No, there was a
Second is
question on
about
the
when
chat
to use
box.
modular and when to use non-modular stem.
Monomod.
He's very specific
Yeah.
about monomod. That's okay.
So in such a chronic case where we're not sure about the version and the offset, better to have a backup of modular stem. And that's what we thought of.
No, this is a modular stem, but what he is asking is probably between Cohn-Wagner and these kind of stems, modular stem. So in this case, actually, you can do a Cohn-Wagner. As Dr. Rakesh pointed out, that the version is not a problem in this case, not much of a big problem. So this is a case where you can use Cone Wagner, but Cone Wagner also you can rotate it too much. But majority of the time, whenever we do a subtrochanteric osteotomy, it's better to have a modular. It gives one more option of preparing the distal femur and then doing the proximal one.
Cecil, you can unshare
Yes,
while
sir.
the next person gets on. I think it's Dr. Rohit Pandey. You can share your screen while we are chatting. Okay.
One question to Cecil.
Yes, yes. Yes, Anil.
Hi,
Good
Raj.
evening, Anil.
Yeah, good evening. Just to check, what modular stem was that he used? Well done.
Plus orthopedics. Plus orthopedics.
Okay. I couldn't.
MRP Titan. MRP Titan.
Yeah.
Oh, was that the
Yeah.
one? Okay. So, what was the distal diameter and what was the proximal diameter? Just out of, I saw the fit. The fit is very good. I didn't have a
Yeah.
lateral view there, but just wanted to check at 6 months. Two things. One is 6 months had it fully united. That could have been the reason for the thing because a well done case. And number two is what was the size distal and proximal?
So it was a 15 into 140 mm, the stem.
Yeah. And what is a proximal like?
12 by 14.
Hard to say.
Paper.
No.
It's
The proximal
The
size,
Body.
diameter of the proximal segment.
Anil, the proximal one comes as a small, medium, long. It comes as a small, medium, long. It doesn't have the length. So
Not the length, the diameter.
it is
Proximal.
you doesn't have an option to select the thickness. It is only three sizes: medium, small, medium, long. The proximal one. So
Small,
the
sir.
Okay.
so based
Sure.
on the small, medium, long, the length increases.
Okay.
Okay. The distal one comes in 140 and then 200.
No, the dias are available till 19, no?
Yes.
19.
Even 21 is there. At
Okay.
if you're using your in between the body and this one, you can use additional augments, but altogether you can get a maximum of 300. That's all.
No. Why, especially in this type of modularity, just a word of caution, especially see, the SRAW modularity is different because that doesn't cause too much of stress at the interface where the osteotomy is. The modular junction is very close to the
Osteotomy.
osteotomy site.
This modularity, in fact, is totally different from the SROM.
Yes, Raj, I understand. That's what I'm
Very
about
good.
to say.
That's a good point.
So
Yes,
there'll be a lot of
definitely.
stresses at the modular junction. Just a word of caution. So if it is not uniting well, the modular
Breakage is very high. Chances very high. Yes.
Exactly. That's all. Well done case, no problem. Just a word of caution when you use such modularity, especially when you use for osteotomy.
Sure, sir. Sure. Thank you, sir.
Thank you. Well done.
Yeah, Dr. Rohit.
Yeah, very good evening, everyone. First of all, I would like to thank IA and Rajkumar sir for the opportunity. So it's a simple case, basically a 60-year-old male who had fall 15 years back while walking on a crane. He has walking with difficulty and pain, instability and swelling in both the knees. So as we can see the clinical photograph from the front, the left knee looks into valgus and the right knee looks into varus. So it's like a windswept deformity. From the lateral side, again, you can see that there was hyperextension present on the left side. On further history taking, there was joint pains in other joints also and complaining of tingling in bilateral lower limbs. This is the gait video of the patient. Before the operation, the patient was like walking something like this. On further examination, there was hyperextension and valgus on the left side. There was swelling in the knee. The knee range of motion was from -10 to 120 degrees. The opposite knee was in varus. The hip was within normal limits, and there were few degenerative changes in the spine. So here I would like to ask, would anybody like to ask some other information in this case? In the history itself?
Sorry, I think I was muted. Rohit,
Sorry.
that hyperextension deformity is always a worry. Combined with valgus, more of a worry. And from whatever history I take and whatever findings, I'll actually go to the extent of even getting investigation done to rule out a neuropathic joint.
Yeah, definitely. So for the same thing, the first important thing was the means competency of the MCL. So on giving the Valgus test, there was a firm endpoint present. And the second most important thing is the neurological examination. So in this case, the quadriceps power was 4+/5, and there was no sensory loss was documented in this case. This is the video intraoperatively after anesthesia. This was the stability of the knee. Doing the varus in valgus. So further blood parameters, CBC was normal, ESR was slightly raised, and also urea and creatinine was a little bit on the higher side, but the patient was taking treatment for the same. This is the X-ray of the patient with which the patient came. This is the AP and the lateral view. And on further examination, I did the scanogram of the patient. And in this, there was valgus alignment present, as well as the angle between the mechanical and the anatomical axis was around about 11 degrees. So just looking at the X-ray, would anybody want to go for some further investigation in this case, apart from the X-ray and the scanogram?
The new quadriceps power is okay. Patient is not spine wise, they didn't have any complaints. There is no much of radiating pain, and so that quadriceps power itself gives you good information that the neurology part is intact. Point number one. Point number two, females valgus deformity, hyperextension. This is a very common combination. So that is one. Second thing is X-ray wise, not much of bone loss.
Yeah.
So
definitely.
this soft hyperextension is predominantly due to the posterior soft tissue. So yeah, so posterior soft tissue, there is some amount of bone loss, but not much. There is a femoral bowing in the coronal plane. So taking into consideration, we have to be very much prepared for distal augments and in the femoral side. So to bring down to the bring down the extension gap. But also this is one case where you should have a hinged knee as a backup.
Definitely.
Always, because this pre-operatively when you examine, it might be okay, 10-15 degrees of hyperextension, but after anesthesia, if you see, that might be even 15 degrees to 20 degrees.
Yes.
So in those cases, you can maximum use is 4 mm or 8 mm distal augments to bring it down the extension gap, but you have to still keep your hinged knee. And then with these kind of hyperextension cases, always be conservative with your bone cuts.
Definitely, sir.
So
as rightly pointed out by you, the most important thing here is the quadriceps power. So it's one of the absolute indication for using a hinge. If the quads are weak, then hinge is one of the preferred implants and the more constrained one which should be given. So I did the scanogram, but CT scan, MRI, and also the NCV study was not done in this case because most of the things were known on the basis of history and examination itself. So looking at the X-ray and everything, the concerns at the hand was the competency of the MCL, because if the MCL is non-competent, then the level of constraint will increase. Also, we have, as already discussed, the reason of hyperextension. So it is mainly divided into a bony or a soft tissue cause. So if it's a bony one, then is there a defect or there is excessive slope after an HTO? And also weak quadriceps will require a hinge implant in this case. Also regarding the approach in a valgus knee, would anybody prefer any other approach apart from the central midline and a mirrored parapatellar with a hyperextension and valgus? Would somebody go for a lateral parapatellar also?
Not in this case. I don't think you need to change your approach in this case. And is there a skyline view? That is also important.
I don't have the skyline view, but
that is important because in these kind of valgus with hyperextension, your patella will be most of the time partially subluxating or even sometimes dislocating.
Yes, definitely.
So you have to be careful.
So the other concern was the bone defect. If it was there, then it has to be managed and you have to be prepared for that. And regarding the patella tracking, as rightly pointed out by you, how it is tracking post-op also and before also, how the patella is behaving, that is very much important. So this is just a simple slide, a little bit, that whatever the deformity is, that gap is larger. So if it's a flexion deformity, the flexion space is larger than the extension one. And if it is extension deformity, the extension space is larger than the flexion one. So in a recurvatum, it is always that extension space is larger. And we should do all the things what we can to just reduce the extension space and also increase the flexion. So there are different ways of doing that. Again, as pointed out by Rajkumar sir, that all the cuts on the tibia should be very much conservative and there should be minimum or no medial release. Already discussed the causes of the recurvatum. So again, the planning is important. So we had 3 parts in this, that we had to manage the valgus, the recurvatum, as well as the soft tissues. So for the recurvatum, different options are there, like a posterior capsular plication, or you can do a proximal transfer of the collateral. But this is one of the things that you can reduce the size of the femoral component. So if the size is larger, the flexion gap is somewhat like this. But if you reduce it, so the flexion gap can increase. Same thing on the extension side, you can increase the size of the insert or you can use a distal femoral augment. So what our plan was to do a medial parapatellar approach, to have a PS implant with a backup of semi-constrained and a hinge one, and to reduce the angle between the mechanical and the anatomical axis from 11 to 9. So it will also give little bit of correction in the valgus. Stem was supposed to be used if the hinge implant or there was a use of sleeve or something. And while operating, we saw that there was a posterolateral defect. So we can appreciate that also at that time while examining also. And on the X-ray also, if we look very closely, the X-ray is not of that good quality, but there was something on the posterolateral, there was subluxation of the whole knee on the posterolateral side. So after doing the distal femoral cut and assessing the stability, there was still some opening on the medial side, and that was mainly due to the bone defect. So we grafted it from the distal femoral condyle bone graft, and I used a K-wire in this case to fix it. After that, there was some means on extension. It was a little bit tight on the lateral side. So the pie crusting was done for that, and following which the balancing was good, both in flexion and extension, and the patella was tracking normally. This is the post-operative X-ray of the patient. So just we used minimum constraint in this case, only a PS implant with the minimum insert. And would the house like to comment on the post-operative X-ray?
Looks good. How's the gait? How's the patient's rehab been?
So after 2 months,
Yeah.
this is how the patient was walking. And this is the range of motion of the patient on the left side. I operated on the right side also after a period of 3 months in this patient, and the patient is doing fine. So little bit regarding the recurvatum, I won't go into the details.
One more thing, Rohit, just for everybody's message, take-home message. These kind of hyperextension recurvatum cases, better to protect them for the first few weeks, like 4 to 6
so
weeks.
means I have that video, but I have not put here. So
no, that's okay.
Even a brace means
that's okay. Brace and keep the
Can
knee.
I add something else?
Yes, sir.
I'm just actually, if I would just say is, it's a case very well done, but I just have one point. The problem with these valgus with hyperextension is that if you follow them up in around 5-6 months later down, they stretch out.
Stretch a lot.
And they stretch a lot. So that is why probably the good idea would be, for me, if I was operating, I would have used a semi-constrained kind of an implant probably. Keep them tighter and then let the physiotherapist and the patient work on it. Otherwise, you get a full correction on table in these patients, and then in post-operative, they just stretch out. And a normal poly, I have revised couple of cases wherein they have come with a broken post.
Okay, sir.
That is actually a valid point. Sorry to interrupt. That is a very valid point. So the message should be like, keep the knee tight, protect it for 4 to 6 weeks in little flexion, and take it slow. So this is the case where I will not hesitate to bring down the femur and make the poly very small, smallest of poly, because later on when it stretches, sometime later you can just change the poly. So this I'm telling over the period of years later. So
sir, I would like to ask one question. So the means in such cases, you will always use a varus valgus constraint at the first choice. If
no, for me, I will go with the PS. That is enough. So
Rohit, I think the point which was made by Ramnik is a very valid one. And if you watch them after 7-8 years, and you will see this being presented also in many forums, that we did this, looked everything good, but here at 7 years down the line, everything has come apart. So what looks good on the table may not be good just few years down the line, and that is a worry. So that is why I think, so that is why most of us actually, when you have valgus with hyperextension, so which means that there was a lot of soft tissue element involved in already in this, and you cannot guarantee that this won't recur again, even though you have filled up with a metal. So the disease process or the pathology is still running around with that patient. He will again end up that. So the best thing, even if you do these cases, it's better to flex your femoral implant a little bit compared to keeping it zero. So if you have gadgets, you can actually do that. So, and probably leave it in 5-degree FFD rather than actually bringing even closer to zero. So that way, even though you might have put normal implants, you will actually safeguard for a few more years. But in the end, I have a feeling that again, they will come loose. So my threshold for even using a hinge in this is very low actually. And I've seen bilateral of these cases coming in, bilateral.
And just to add Rohit's point is, Rohit, what you were just asked, going from this to a PS to a TS, let's say a semi-constraint, is in this kind of situation just adds a slightly a bigger box cut. That's it. Nothing else actually. Rest of all will just be there. Or if you don't want to use it, then with a normal femur, you can use a semi-constrained poly as well, with the stem down.
Okay, sir.
Ramnik, in some other implants, you don't even need a bigger cut. It's just the poly which changes.
Yeah, just the poly which changes. That's what I'm trying
just
to
the poly which changes.
Okay, sir. Point well taken. Thank you so much. So,
But
sir,
it
the
is
message
good
is the
done.
conservative cut should be there, especially on the distal femur, smaller femoral component size to increase the flexion gap, and minimum releases on the medial side. Assess the quad strength. If weak, you can use a hinge implant in such cases. So, thank you so much for your time.
Good.
Yeah, you can stop sharing while Dr. Mandal can, Anand Mandal can start loading his talk. I think this was a post-traumatic case. The posterior capsular structures would have been stretched out right at the outset. So all the more reason to be a little more concerned. Dr. Anand Mandal is there. You can share your screen.
Otherwise, till he gets ready, we can ask the next
Sathish.
speaker.
Yeah, Dr. Sathish, you can load.
Yes, sir. I'll load, sir.
Please load.
Yeah, please.
Anand is logged in. So where is he then?
So let him get ready. Before that, we can
Okay.
finish Sathish. Yeah, Sathish.
Sir, please.
Share.
Yes.
Yeah, good to go.
Yes, sir. Yes, sir. Sir, at the outset, I would first like to thank Ajit sir and Rajkumar sir and IAA for giving me this opportunity. The case which I am sharing today is revision hip in low resource setting like our government public sector hospital. So, a 65-year-old female with no known comorbidities presented with complaint of pain and swelling over the left hip for the past 4 months. She had a history of total hip arthroplasty done some 10 years back, but she did not have any records on hand as all the records were lost in a flood. So this was the X-ray with which she presented to us. We could see that there was a proximal migration of the cup in the iliac bone. Our ESR and CRP was also negative at the time of presentation. Other routine investigations are also found to be normal. We did not have an MRI with this digital subtraction software, so we couldn't do an MRI at that stage. And we did a CT-guided aspiration of the left hip, and it was 50 ml of this serous fluid. And it was actually sent for culture sensitivity and also for CMINAT. And all tests were found to be negative. So coming to the management, of course, there are a number of articles to state that both can go ahead with the single stage as well as two stage in case infection is being suspected. But since all the parameters were normal, we thought we'll go ahead with a single stage revision THA. So so we put her on upper tibial pin traction so that we could bring her femur down, and she was on pin traction for about 4 weeks. But to our surprise, intraoperatively, what we found was we found a lot of white caseous material which was there, and so we didn't want to proceed with the with the procedure, and hence we took a biopsy of all the white caseous material, which is indicated by the arrow, and then we also sent them for culture sensitivity and the CBNAT. And we are only able to retrieve the cup, and we kept on antibiotic beads just for safety, and then we abandoned the procedure. So this was the immediate post-op X-ray after 4 weeks, and we were surprised to see that all our test reports were again negative, and this was a CT scan which was done to assess the bone loss, and we found it was Peprowski 3B, and hence this time we equipped ourselves all the armamentarium which was available with us. So we planned for a 2-stage revision, and this was after 6 weeks of pin traction. You can see that the femur has come down to almost at the level of the sternum, and then we used an allograft from our bone bank, and then we used a cup cage construct. This is locally available to us. It was from plus of size 52. And then we did an ETO, and we used a cemented long stem and the SS wires to hold them. And we also ensured that it was stable intraoperatively, and post-operative events were also uneventful. So this was at 2 months and 4 months follow-up, respectively. This was 1 year post-op, and this was 1 year post-op, and this was a video at the end of 1 year. So this is what we could do at our center, and we just want to know the opinion of the experts and the house on what could have been done better.
Yeah. Why pin traction, Sathish?
Sir, because initially when she presented to us, sir, there was no yield at all, sir. It was severely painful, and she was not allowing us to examine also. So, and it was a high riding one. So we just wanted to take some time to bring it down. So we used a upper tibial pin traction, sir.
The problem is the pin site itself may be a focus at 4 to 6 weeks. That's an issue. I think by and large, most people, if at all it's very tight, would only think of releasing, getting the soft tissues sorted out. And nowadays, I don't know if routinely, anyway, surgeons generally put on traction, unless, there is some other issues. Maybe the decision making for revision, if they are not keen on that, something like that. What are the thoughts, Rakesh and Rajkumar and Ramnik? Even Anil is there. Anil, please, you're in a medical college.
Actually, my first question was that only. I was about to ask Dr. Ajit to ask the same question. Definitely, I will also say no pin traction only, because whether it is a distal femur or proximal tibia, that 6 weeks is quite a long period. In fact, the very high chance for all other complications related to pin traction is very high. That is one. Second thing is, in a type 3B, which is like almost like a up and out. So even unless you suspect a pelvic discontinuity, most of the time with the proper X-rays in a setup like this, what you are explaining, a good Jude views will give you a lot of information about the integrity and the bone loss situation. So an augment and a cup, highly porous cup on this thing will be a option to bring down the cup down and get a third point fixation superiorly. So that will be the next one. And another thing is, whenever we are doing an ETO, I will prefer a distal loading uncemented system when compared to a cemented long stem. Nowadays, even Wagner uncemented stem, it's not very expensive, Sathish. I know still that 50,000 rupees will be a big for that patient. I understand. But preferably to use a distal. I know if you see the cemented guys, they're writing 10 guys and all, they will say that revision with the, but those patients, those techniques are all with the impaction bone grafting. They do a lot of impaction bone grafting for bone loss, and then they do a cemented system. So where it is almost like preserving the bone, regrowing the bone for that concept. Otherwise, an uncemented system will be a better option.
Anand can load now while we are talking. Anand Mandal can load while we are discussing.
Yeah, Satish, just to quickly add, I think, yeah, we all have this resource crunch issues. But I think now, present day stage, I think this bone, the cages with the bone, where did you get your allograft from? That is a question.
That's local, he said.
Local. Okay, no issues. See, the allograft can be used, not an issue. In fact, it's a good source, good this thing. But how to cost cut? We have also realized one of the Zema augments. See, if you combine just one augment, you don't have to use a huge posterior superior or anything, because one augment, the single augment cost is only about 60 or so. No, this is how to titrate the cost. And with a bone graft, that gives you a good long-term stability as well. And you can use it with one of the porous coated cups from one of the other companies. You don't have to use TMAS type of thing. That's how you bring down the cost. And as Raj rightly said, Wagner is another stem which is more distally loading, and it's a cheaper option. So if you could just pool your resources only for the implants, and that's what we often do, that would be a good thing to do. But having said that, bone graft in cage is a very good option that you've done. So there's no taking away from the fact that this is a job well done. But if given a choice, and if you have to titrate your resources, this would be the best bet.
Yeah. The acetabular side, as Anil said, the bone grafting, it may not be a biological fixation, but still we have published 52 cases of just bone grafting, and then this Muller's ring, reconstruction ring with cemented cup with 11 years of follow-up also. So
well said, Raj. But even we have put that in IJO, the fate of bone grafting. It's very, very unpredictable, because long term, what happens is after the failures or the things are seen at.
I'm telling about this situation. In this situation,
correct. Very true, very true, very true. But it's a little unpredictable. So I was just saying that this is. But Sathish, well done. I must say that your cage was well positioned. Your graft was there. You must have put in a good this thing. So well done. I guess we are all battling with this resource crunch and settings. It's not an unusual situation for all of us.
So Anil, Rajkumar, and maybe Satish, all the guys who are working with Plus, this stem always looks very flimsy to me, very small, thin down. How good it is in long term? And does this bend or break this stem?
No. You're talking about the cemented one, Rakesh.
Yeah.
No, see, like I said, my choice, I would put it on Wagner, Rakesh. I wouldn't do a cemented.
No. I've seen some stems from the company which are uncemented also. They also look very thin and slender.
Yeah. I'll tell you about that. I know what you're talking about. Biorite medicines. That is the only select situations where the Wagner 14 starting size doesn't fit. Then I may have to go down to a 12. I've done one or two so far. So far, they've had some issues with the earlier ones. The company admitted that. The earlier size 12, which tapers down, they had some earlier issue. There was a breakage and all, but I believe they've sorted it out. I've done one or two because I had no other options, and it's holding well so far.
This they have used a thinner stem because it's a cemented, if I'm correct, Sathish.
The problem with these long cemented stems is I've actually taken and revised them quite a lot. They have a viper effect. So basically, in the ETO situation, the cement has actually not percolated round into the cortical matrix. So when it's all of a distal fixation, it's working as a distal fixation with no hold proximally. So with the windshield viper effect, they actually have a high tendency to break these long stems.
Yeah, so that's all the more reason why the Wagners are doing very well actually.
Wagners and Anil for this size 12.
Any titanium distal loading step.
Well, only for this, Anil, if you see.
Okay, I think we'll go on with the next one.
Yep.
I was just adding is that a size 12 is very good.
Yeah, and Dr. Anand Mandal can go ahead.
Dr. Ananda, any issues with your link? Hello? Dr. Mandal?
We seem to be stuck here, is it?
Yeah, that's what I'm wondering. I thought I was on a...
No, I think we are stuck with his presentation.
No, but why is he not got the link? I mean, we are not able to hear him.
No, he has to click on the center screen once and then take the button. Now it's going. Yes.
But can we hear him?
We can't hear him.
Is
he muted?
He is muted. Now yes. Now he is talking.
Hello. Okay, শোনা যাচ্ছে না?
We can't.
So Dr. Mandal is saying that he is not muted, so I don't know why we can't hear him.
No, he is muted actually. Now only. One second.
Ananda, I can hear you. তুই এটা কাজ কর, তুই ছেড়ে দে, let the next guy present. We'll see what we can do, sort out.
Yeah, unshare.
I think Dr. Sumit Anand is next. You can share.
Yeah, I'm sharing.
Yeah. Yeah, please proceed.
Yeah. Thanks for the opportunity. I would like to present the case of this 43-year-old lady who had pain in both the knees and difficulty in walking with stiffness. She was a known case of rheumatoid arthritis on treatment on and off. No other comorbidities were present. This is how her gait was preoperatively. On radiological examination, this is how the X-ray looked like. On right side, we can see the bony trabeculae crossing the joint line, indicating a bony ankylosis on the right side and advanced arthritis on the left as well. Again, on lateral view, there is the ankylosis is seen between tibia and femur, as well as the patella is stuck to the femur. So concerns or challenges were whether we should offer a knee replacement on the right side or not, because she might not be having too much of pain after surgery. She might have some problem. So she was counseled and she wanted a painless mobile knee. So we went ahead with total knee. options were different for approach, how to determine the joint level, what implants to choose, how to gain some movement, and what would be the rehab protocol. So should I go ahead with the what we did or
Yeah,
I
Sumit,
think
go
we
ahead.
can have some discussion.
Yeah, please.
At this stage.
Hello.
So any youngsters want to butt in? Think of something, some points.
Sathish, you're there? Satish, Vishal is there?
Vishal is there, I think.
Yeah, Vishal, Satish. If Satish, if this is in your setup, how will you take it? Proceed.
So I think if nobody is coming forward, I think we'll carry on. I think the problem starts off.
Sorry,
first of all,
I missed that, Ajit. What was the question?
no,
No,
how
at this
to
stage,
proceed.
how will you proceed? Any important points?
Yeah, no, still the question is the diagnosis. What has happened to this lady? And
She's
it's important to know.
rheumatoid, sir.
She's rheumatoid. Okay.
Yeah.
Right. Generally, we don't see such sort of bony ankylosis in rheumatoid.
Satish is there? He has come.
Yes, sir. Yes, sir.
Yeah.
Yes, sir.
In your setup, how will you proceed? This patient wants a mobile knee.
Sir. Because, sir, we have a... Sir, we need to rule out in, other conditions also, sir. Which is the infective etiology and all.
No, all that is sorted out, Satish. All that is sorted out. This is rheumatoid. She needs surgery. How technically, how will you proceed? I mean, steps wise, planning wise, that sort of thing.
Definitely, because with our implant, it is definitely literally not possible in our center, sir. Because
Okay, Sumit, you can go ahead with the points.
Okay, sure.
Yeah, so we'll answer this one. So basically, you go with the standard approach. You try to take away the patella as much as you can. And from whatever gap you need to take a sliver of the bone of the patella from the upper tibia, very sliver of bone. And that gives you a release so that you can start bending the knee a bit more. So from a difficult situation, you can convert it. I would prefer not to cut femur because some people I've seen actually cut the femurs. And I think that makes difficulty now to judge the joint line. So best is to cut a sliver of bone from tibia. Be very careful on the back side in the center. So don't do in the center, just on the both sides. And then just use a slight force and do an osteoclasis.
Thank you. Rajesh, for me, it's a trapezoidal wedge is what I normally like to take.
Yeah, so
after I cut out the
absolutely,
patella.
yeah. So I didn't describe the whole way, but that's how you do.
Yeah, so we went ahead with the medial parapatellar approach, but we were not able to retract the patella. So we used tibial tubercle osteotomy for the exposure part. And then though the joint line is, the depression is present there and the soft tissues are generally present at the joint level line, we tried to confirm on a C-arm view as well. We took out a wedge of the bone to create the joint line and then did the rest of the part. Because the bone was very osteoporotic, we used a stem on both the femoral and the tibial side, and then used some screws to close down the tibial tubercle osteotomy. This is how it looked immediately post-op. And she was started on an assisted knee flexion extension initially. This is how it looked after 1 month post-surgery, and eventually left side was also operated. So the thing is, we did not try quadriceps snip at all because in our experience, the results are not good. There is some extension lag with snip, and TTO gives a better result. More so, a bony ankylosis in a knee with flexion deformity is easier to do, but a knee which is stiff in extension, there is more problem with gaining range of movement. So likewise, this is one of the cases that we did. The knee was bony, fused in as a bony ankylosis in 90 degrees of flexion, and the range of movement was easy to achieve. But in knees which are fixed in extension, it is more difficult. And I think most of the time, tibial tubercle osteotomy is helpful in gaining some movement as well, because we can proximalize the osteotomized fragment.
Can we go back to your TTO, the lateral view, doctors?
Yeah.
See, one of the things, there is sometimes this sort of an osteotomy, it pulls up. So the patella gets, further up. So there is one described technique where just below the prosthesis, you create, not the prosthesis, when you take the cut, you create a ledge-like thing, and then you push your osteotomy fragment, distal fragment, into that so that it doesn't pull off.
Migrate.
When you do that, you can just get away with sutures or even, just wires. You don't have to use so many screws as well.
Yeah. So this is one of the
worries is it gets pulled off.
Yeah. Now we are using mostly ethibond sutures or wires. This is one of the earlier cases of T2. We used to have screws there.
Yeah. So I think in
I think, Ajit, what you described was that step cut osteotomy.
Step cut, yeah. So it's like a ledge there on the top.
Right. So you just leave that small piece of bone anteriorly.
Chunk, about a
and
centimeter and
that.
a half. Yeah. So yeah, in such a situation, it's I think just good enough straight away if you go for a tibial tubercle osteotomy, rather than huff and puff and try to snip, and finally you'll end up doing a turn down there, Coombs turn down or whatever.
How old is the patient?
43.
No. Right. Can we
That's
have
okay, I think.
Anand Mandal now?
Yes, sir. Sorry for the inconvenience. Can you hear me now?
Yes, very much.
One moment.
Very loud and clear. Good.
Dr. Sumit has to unshare the screen, and then Dr. Mandal has to share his screen.
Yes, I'm trying to say.
In the meantime, Rajkumar, can I just ask you, is TTO an absolute necessity, or how many? Because TTO has its own fair share of complications. In the second TTO in this session that we are seeing.
Yeah,
and to tell you, I've never done a TTO till now, and I don't know why I've never, but I have never actually relied on TTO and never needed to do a TTO.
Yeah, even I was about to raise that question here. What was the indication? But he mentioned about the extension.
Ramanik, I am much older to you. I have done 3.
So with considering, because the thing is, these kind of cases, what I have realized is they stiff knees and ankylosed knees. The moment you take off the patella and you can thin out the patella, you have a lot of space going up and all. It's more of adhesions and tearing the gutters.
Yeah, for an ankylosed,
I have a lower indication for TTOs. I've done at least 7 of them, I think, so far, including in tubercular ankylosis and that sort of thing. Anyway, you are the second Delhi man who says he has never done a TTO before that I've heard.
I've never done it.
No, I've done around 4 to 5 cases for a very gross stiff knees to avoid
the thing is, TTO has its own fair share of complications. Maybe next time I'll present a case of which landed in my OR after a TTO which failed. And
no, Ramanik, now after seeing all the results of TTO, the metal augmentation for a TTO is not needed. That is for sure, which is the main reason for failure: cut through, bony fracture, all those things. So I always use only ethibond, no extra K wires or SS wires or screws. No, only ethibond, and it works well. That too, patient can start bending the knee next day. This ethibond results I saw with Ridian Morgan Jones, and I started using, and absolutely it is giving me good results as well. Not even one failure, touch wood, with the ethibond.
Okay.
Same, not just, I mean, Ethibond, none of my TTOs have failed. None of them have got pulled off. I mean, even when I did the first case, I think probably proper planning and execution, that's what matters. People who are unprepared to do that and then they do that on table probably end up with problems.
Thickness matters, the lateral sleeve matters, that soft tissue sleeve. We should not go and release the soft tissue so that it hangs down, hangs up in the air, the osteotomy. So that small things, I think, should be fine.
Okay. I think we'll get on with Dr. Mandal's case now.
Yeah.
At last.
Good evening, sir.
Good evening.
I must express my thanks and gratitude to the Indian Arthroplasty Association for giving me the opportunity to present the case. It is a case of bilateral total hip replacement after infected non-union of the subtrochanteric fracture.
Both sides infected?
No, the right side is infected only. Second. The slide is not coming. Yes. It is a 43-year-old female, met in road traffic accident on 16/10/2019, and this is the first X-ray with which she attended to an orthopedic surgeon, and
Looks like bisphosphonate induced fractures, really.
Miss, sir, it was due to the road traffic accident and in a 43-year-old female. There was no history of bisphosphonate taking.
No, just the typical fracture pattern I'm talking about.
At a typical bisphosphonate-induced fracture like. And she was operated on 26th October 2019, like left side with the DHS and right side with DCS. Now, patient went to the second surgeon due to the infected right hip and associated with the non-union and also the fixation failure. And the left side is still not united. And this was the first X-ray after of the right side after fixation. And the DCS was removed and debridement done by that surgeon on December 2019. From the X-ray, we can see that there are sclerosis of the proximal fragment of the femur. And after 2 months of the removal of the implant on the right side, proximal femoral plating was done by that surgeon with antibiotic cement beads. This is the post-operative X-ray. Now, the left side also went on non-union and he removed the implant and also debridement done on that side, because at the same time, there is no available history or discharge certificate of that surgery. At the same time, he did not do the fixation of the fracture. So I am suspecting that there may be infection on the left side also. Now, again, after 2 months of removal of the implant, he fixed the fracture with the interlocking nail. On 2023, patient presented to us with the problems like this: the left side non-union subtrochanteric fracture, also non-union neck of femur fracture, and partial resorption of the neck, right side infected non-union with screw cut through and the proximal femur bone loss, and the patient is bedridden from the after the road traffic accident. That is about 3.5 years. And there is pain on her right hip more than the left hip. Now, This is the X-ray with which she presented to us in a government hospital, government medical college. And there is no discharging sinus, but I suspect that there will be infection because the pain is on the right side more. I suspect that the pain infection is present on the right hip. So what can be done in this situation? Sir, what can we do now?
Yeah, I think.
So now how old is the patient?
Now she is 46.
So in 3 years, he's not going to grow too old.
The thing is, radical debridement resection of all the avascular bone there, that's going to leave a huge void. And then culture-specific antibiotics for a long time. I mean, she will need a central line.
And keep
in
your
the
X-rays
interim,
on.
Yeah, in the interim, how to, I mean, I think I would put a cement spacer, I think, vancomycin loaded or whatever loaded, cement spacer, weight.
That investigations?
I mean, yeah.
So Anand, in right side, I think the decision is much easier. That you need to take out all this metalwork beads and then put a cement spacer, because that femoral head and subtrochanteric area is gone.
Yeah.
The left side, you also said that there was some debridement done. So we're not sure that whether there is or there isn't an infection on left side. So that probably at the same time when you're doing this, you could probably approach this area and re-debride and actually check whether and send samples from here, whether this is infected or not.
Surprisingly, the neck fracture wasn't there when the nailing X-ray was put up. Now there is a fracture there.
Now there is, yeah.
Some sort of a stress fracture
So
or
that's
God knows what.
iatrogenic probably.
Or maybe due to the fall at home, maybe because there was no fracture after the interlocking nail have been done.
Anyway, the challenge on the right side, we can proceed, I think.
Okay. Now that what I have decided that I will do the debridement as sir said, radical debridement. And during debridement, what I see that most of the bone in the proximal fragments are dead. And there is a coronal plane bone loss in the head of the femur also. Because of the repeated operation, DCS and the loose implants, they are loose through there. There is coronal plane bone loss in the head of the femur fragment and neck of the femur. And we sent the tissue for the culture and sensitivity. And at the same time, I have done the antibiotic cement spacer on the right side.
So did you take any sample from left, Anand?
No, I have not taken because at the time, it seems to me that it is not infected.
Okay.
For that reason, I have sent only the debridement and sampling. I have done from the right side only. And after, it is not about 3 weeks. Most probably it is after 6 weeks, the ESR, CRP are all reduced. And the I have done first that the patient is bedridden for 3.5 years. So I have to do the patient mobile first. So for that reason, I decide to do the THR on the left side first. And what I have done, a long stem uncemented on the femoral component and cemented on the acetabular component, because there was available acetabular component, non-cemented acetabular component was not available in our setup at the time, and it was very small also. It was about 42 size. So I have done the uncemented femoral component and cemented acetabular component on the left side. After that, I decide to do the right side, and Unfortunately, I have not used the Siam at the time. I reamed and put the cement on the femoral medullary cavity, but the stem was outside the medullary cavity. It was like this. And it was a constant type of hip on the right side. On the next day, I revised the right side with a cemented stem and keep the constant hip there. Now, these are the lateral view of the left and right side. And this is the recent X-ray, which shows that the left subtrochanteric fracture femur have united well, and the right side is also good, but patient is still walking with the help of the walker, but there is no pain. And she is happy than before. But I have to it is post-operative almost 3.5 months on the right side. Thank you. I want to know what was the better choice for the right hip.
Ananda, can you go to your X-ray? Just the first post-op.
Since she's a young lady and with a constrained liner and with so much of bone loss proximally, she's not going to last long. And ideally, if you're asking, I think probably allograft would have been a good option, but all these constraints are there. I don't know, maybe under the circumstances it's okay, but then she's not going to last long.
Yeah.
The hip is not going to last long, yeah.
So there's no abductors on this side, isn't it, Dr. Anand?
Yeah.
Yeah, small pieces of bone with the abductors was there that I have attached with the stem only, but it will not united, so it will not work.
Okay.
So
And
considering
tell us the trick. What did you actually do the second time when you found that your hip was outside?
I thought that I have to cut the constant ring, but it is very difficult to cut a strong ring like this. So I detached the taper stem from the head, and after putting into the medullary cavity, again I reduced it to the head.
So it's the same stem you put it in because it was cemented before, isn't it?
No. The stem is different this time.
Or it's a different one. Okay.
Yeah.
What stem is this one?
This is solution, I think. Is it
This
solution?
The left side is solution, not the right side.
No,
Right
right
also
side
is-
stem is local made stem.
Left side is solution.
Yeah.
Okay.
So Anand, the first thing is, as Dr. Ajit pointed out, this stem looks thin and approximately no bone, no support, constrained liner, chances of fracture very high of the metal. The left
Yeah.
side also, some stems, sometimes many a times in an old age patient where the activity level is not that much, these solution stems survive without much of problem. But still, I think the message should be for everybody is, given the situation as a reason, we should stop using these cobalt chrome stems. So we can even use a local made titanium stems, but this cobalt chrome stems on the acetabulum side, I accept a small femur osteoporotic. You have used a cemented cup, that is okay. But for the stem wise, I will suggest 99.99% better to avoid these stems. And in fact, the company itself, they are all pulling it out. So once it breaks, it's a nightmare, I'll tell you. With all those things to remove it, trifines and all those things, total nightmare. I have removed couple of these broken solutions and ecleons. So whatever might be the age or the situation, better to avoid these cobalt chrome stems.
So they are not
Dr.
solution,
Mandal
they are
can-
problem.
Dr. Mandal can de-link and Dr. Arun Kannan can log in, I think.
No, I think, Kajit, we can discuss this case a bit more. So
Yeah, but
this
the
was
X-ray
quite,
need not be there.
Keep this extra because I think this was quite innovative. That I don't know, what would you all have done if you found that the stem was outside and you got now this constraint liner? Would you have thought about what Dr. Ananda has just done?
First of all, the constraint liner was used for deficiency of the abductors, is it?
Yes, yes.
Why you didn't think about the dual mobility?
Don't know.
I actually
I
know.
think even
Actually, dual mobility stem is not cannot be used in our setup.
Okay.
There is the government is not supplied in our
Okay,
setup.
okay, no problem. Right.
I have done it almost. The patient was admitted for 3 months there, 3 and 4 months there.
Raj, in this situation, dual mobility, does it have a role in the sense the whole problem is outside of the cup? That's the abductors.
Yeah, abductors and the proximal femur also.
So basically the reason for dual mobility I asked is if the constraint liner is used predominantly for deficiency of the abductors and soft tissue problem offset soft tissue tensioning is the problem, then the dual mobility reduces the chance because of the abductors weakness. But if that abductor is totally gone, no this thing, in fact it is better to use something, get a plastic surgeon's help and then try to reinforce the abductor mechanism itself with some graft, everything. So but still straight away for that abductor deficiency to use a constraint liner, it adds still more riskier down the lane.
Sir,
Can I just add something there?
Sir, where we have to attach the abductors here?
So can I add, Dr. Anand, to answer your question also?
Yes.
A very innovative technique which is used by the oncosurgeons in this younger age group when they do such cases, if they have a large resection.
Fiber mesh.
They use those mesh, the hernia meshes which is used, and those hernia meshes all across, and they keep tying their abductors and all the muscles that they get around that area. And it actually forms like a cover, like a hood on top. And once it consolidates, because a lot of it heals with a lot of adhesions. So the long-term chances of it working for even 10, 12, 15 years, that's what my onco guy here tells me. It's very great. I have not done it, but that is a very good thing. I've seen him do it.
No, Ramnik, I have started doing it actually. We've done a few cases with this hernia mesh. Or you can even get marlin mesh. But I use the hernia one. And
so
it's
in
a very
this
good,
case,
very good
probably
way
a
of
proximal femur replacement along with the mesh and everything probably would have been a better choice, Rajkumar. If cost is not a constraint.
I will not straight away go for a proximal femur. I will still go for if the abductors and then go for a dual mobility cup side, reinforce the abductors and then try to use a titanium stem, because even we have seen see in extensive proximal femoral bone loss, when you use a titanium distal loading stems, we don't see any much of big fracture. You put allografts and try to reinforce the abductors and everything, so it all forms like a fibrous tissue or that, and then you don't see much of fractures. And this lady, looking at that, she's not very grossly obese or anything like that. First point. Second point is she's young, she's not very old. So straight away using a proximal femoral processes, tumor processes, we use it as a last resort, try to build up one by one. And because she has already undergone so many procedures, so the constraint itself will cause chances of breakage for this proximal femur, the constraint. So try to keep it minimal and then go step by step. That will be the approach, better approach, I would say. But with the situation and the limited constraints, these what we are discussing is all with the best options available. But with the limited options, I think this is he has now given at least a patient not walking for the past 3.5 years, 4 years, and now at least the patient is walking. So let it survive as long as it survives, and that it should be.
So how many operations has this patient had, Dr. Anand?
She told me that 13 times he went to the
But I
operation
think we
theatre
should give a
for
round of
these
applause
two.
to the patient also.
For these two surgeries.
Okay, you can
Stop sharing.
Stop sharing
You
the
can
screen,
stop
Dr.
sharing,
Anand.
Yeah.
Next is Arun.
Arun.
Uh,
6 months back, 4-5 months back, I revised a broken solution stem, and I had to almost go to the local shop to get all those striffines ordered and all those things, and that striffine started breaking.
Well, see, that's the funny thing. A company knows they have it, problems, and they also bring out the solution. Those solution for to remove all the solution stem, broken solution, they have those defines. So to remove a solution, they have another solution.
It was like, oh my God.
Ramnik, we shouldn't call it solution anymore. We should call it problem.
Yes, it is a problem stem.
It should be banned actually, straight away.
Yes, Arun.
Yeah, yes, sir. Good evening, all of you. Thanks for the opportunity. So this was a 40-year-old patient. In 2011, he had undergone a cemented THR for AVN. Oh, sorry, she. So she had undergone a cemented THR for AVN. And this was 8 years after the primary. This is when she first saw me. So infection workup was negative and the cup was loose. So at this stage, I had suggested revision for her, but she went elsewhere. So I did not have a CT of her at this stage. So at this stage, I mean, the questions are whether to revise the cup alone or to revise the cup and stem. Let's go back to the X-ray.
Arun, you're asking us or you're asking yourself?
Yeah, I'm just asking you, would you revise both the cup and stem?
No.
Because I had
So,
suggested.
The X-ray is not very clear, but
if you look the cup, cup has of course completely dislodged from where it probably would have been put. But if you also see the between the head and the cup distance all around, we can see that there is a wear out which is happening. So somehow this patient has got accelerated wear, and that has trickled down in the stem also. I'm pretty sure that if you had looked the stem before and now, you can see some radiolucency around the stem.
yeah, the distal to the tip, stem tip also, there is some, if the X-ray is not proper, but you can see that there are signs of lysis, loosening and all those things.
Yeah, so I think this poly is already wearing out, which has trickled down and caused poly disease also. So if you have to revise, you have to revise both. The only good thing is that there is a technique called cement in cement revision. So if you are not too bothered about taking out completely, you can do that if it's an old or friable patient.
So then she went somewhere and got revision done for this. So this is what they ended up putting based on I think based on the work they had to do an ETO to get the stem or whatever. It was probably well fixed at this time, or the cement mantle at least was good, and they did this. So this is when she presented again to me about a year after the revision surgery was done. So this was the.
This also looks loose at the tip now, the stem.
Yeah.
The cup looks fairly well fixed.
Yeah, of course, looking good. So, and if you see again, infection workup was negative, and you can see it was almost. She was a fairly short lady. So even,
yeah, I think you're in trouble now because the stems actually come all the way where the widening of the femur starts.
Yeah. So again, infection workup was negative. What would be the options?
Luckily, there is some that small isthmus bone is intact, the distal. But the entire lateral cortex seems to be gone. The proximally.
Yeah, proximally near the trochanter, it's all gone.
On the metaphyseal region, everywhere, the lateral cortex is gone.
I think they probably did an ETO, but somehow managed to have combination of those fragments.
Gone.
And while wiring up, this bit completely disappeared.
This is probably the case which has this thing reef written all over it.
Yeah, it's a reef solution now.
But Ramnik, a patient,
No,
he said, a very short
that's going to be a
patient.
challenge.
Yeah, so
Short
there is
patient,
one,
so
one
will
more
not
option
need a
you
reef.
can have.
You will not need a reef here. A modular
more
stem
option
is a
you
good
can-
one here.
Yeah, so modular distal taper, and I think we can still get this taper fixed here.
Yeah.
And but I'm just worried about periprosthetic fracture. So I would actually span a whole plate also across it.
Considering the medial wide or thick cortex, a reef will be very difficult to get down there without,
Not in
coming
this
out
lady.
more laterally.
And I think we should leave reef for the next stage. This stage, I think we can get a distal fixation, but we need to span and protect the whole femur. Otherwise, she'll break.
Okay. So
Yes, Arun.
yeah. So I'll just go on to what we did. So initially, I mean, the stem was loose, very loose, but it was not coming out because the GT was hitting against the shoulder of the stem. So I removed the wires and did a digastric osteotomy to kind of, there was not much cortex below, so it was not like a case for an ETO. And then we had to get past that pedestal, and then I had both reef and the Wagner stem arranged. But with the Wagner, we had a good fit. So this is how it looked like. It just got past the pedestal, but it was having a good stability. But what I've done in a few cases like this, I've had a good number of cases. So I just put about proximal 1 inch or so of the stem, little bit cement just around the top of the stem. The rest of it is all uncemented. So this was the immediate post-op picture. So kind of a hybrid fixation of a Wagner stem is what I employed for this patient.
Is it a prescribed one or a documented one, or you have just tried yourself?
Yeah, I've done about 12 cases. Not, I don't see any. It's like a little bit like the TKR stem where proximally we do a hybrid fixation with cement and the rest of it is uncemented.
Why was this? Why that cement you were used?
I've had 2 cases in my I mean where it has subsided, and the Wagner stem, it's about 15% subsidence with Wagner stems is noted in literature. So
what is the thickness
that
of the stem?
The stem was 16 and 265, sir. 265 stem, that almost goes so much down for her. It's not a 305 stem.
So the reported subsidence, whatever is, it is also the Wagner, the splines and the stem profile and the taper, everything put together, it has got a good incidence of subsidence. But at the end, the fixation, the rigid fixation matters when it comes to the subsidence. I've seen cases where whenever you have on table, sometimes we think that it is a line-to-line reamer. But in majority of the cases, it is not the same. So it is all narrows down to the preparation. First point. Second point is the concept of distal loading is, even though you can even keep the stem shorter, like in the sense you just need a 2.5 centimeter to 3 centimeter distal to the ETO site or wherever the bone loss is there, and the scratch width has to be 2.5 to 3 centimeter. So that is where you get a good fixation, and if it is thicker the stem, better to prevent the this thing. And that is where the improvement with the read-up stem now. If you see the read-up stem, apart from the bigger splines, they have the smaller splines also. So in the read-up, so the fixation is still more better with the read-up stem. And they also come out, they have this proximal body sleeve-like thing to negate the proximal femoral bone loss, huge bone loss. But it is expensive that if you use that sleeve, but that is also an option. But I don't know how much this has got an advantage, because the whole concept of the stem is the titanium bone implant itself should enhance the bone integration and then the bone growth, where the entire soft tissue sleeve and the bone together helps in bone formation. So you put a lot of allografts and then fill in with the stem with a good distal fixation, you get good consolidation of the proximal bone also. That is the concept. But the cement, I don't know how much it might.
Yeah, this is probably just in the one, probably an inch, just in the proximal most portions. Not, I mean, it's not like.
So don't you think it will give you a false fixation in the proximal before even you start loading the distal one? So the whole concept of making the distal portion uncemented and then the proximal bone, the load, how it is getting transmitted may in fact hinder your osteointegration between the bone and the implant. Rakesh, what is your opinion?
Yeah, there's something very novel to me. I don't know how much of that cement, particularly when I don't have a bone on the lateral side, how much will it actually help me to give me stability? So not very appealing, but if that works in his hand, that's fine.
Yeah, I mean, I think I presented this maybe 4 years back. I had about, not all cases of Wagner's time I've used cement, cases like this that are osteoporotic and with a fair amount of bone loss, I've used this technique.
How old is
Not
this
all
patient now?
Yeah, I'll just go to that. This is 1 month post-op and then...
age, Arun?
She was 48 when I operated.
48, okay. Right. Good. I
Okay.
think we should have a
You can
follow-up
stop
of this
sharing
patient
and then Dr. Ratna Kumar can share his screen. We are past 9 now, 9 o'clock.
So how many more to go, Ajit?
Last one.
Last. Okay, let's finish up.
You're hungry, Rakesh?
No. I've been cheeky today. I've just had my dinner.
How is the Kolkata situation?
Not very good here. We can discuss that after this, but it's very bad.
Burns and fires and all those statements.
Oh God, it's a nightmare. This is the longest running agitation by doctors. Longest. Before it was about 13 or 14 days, I remember. This has now crossed 19 days.
Yes, sir.
Okay, Dr. Ratna Kumar.
Good evening, sir. Today I'm presenting 2 cases of extensor mechanism injury post-total knee arthroplasty. I'm fellow under Dr. Ramnik Mahajan, sir. I thank IAA and Ramnik Mahajan, sir, for this opportunity, sir. So first case is a 62 years female patient who had bilateral TKR 1 month earlier. And now she had a history of fall and she came to our OPD with complaints of pain and swelling in the thigh and knee region of the left side. She's obese with BMI of 31. Associated comorbidities had hypertension. On examination, she had diffuse tenderness over the thigh and swelling was present. Range of motion was active flexion, 10 to 60 degrees was present. There was no active extension. There was no active straight leg raising. Neurological examination was normal and patient also had difficulty in walking. So investigations, this is the initial preoperative X-ray before the bilateral knee arthroplasty. So this is the left side immediate postoperative X-ray. And this is the current X-ray which she has come with. The components look well aligned. The full length femur X-ray shows no bony injuries. So we went ahead and got an ultrasound done. Ultrasound showed a tear in the quadriceps tendon, which is approximately 4 centimeters, and it is 3 centimeters proximal to the patellar superior pole. So I would ask the floor, what is your plan if this case comes to your OPD, sir?
So I just want to say one comment on these, that we used to hardly see these sort of injuries before. Maximum we used to see was patellar fractures. And now we are beginning to see a lot of tendon avulsion from the tibial tuberosity, tendon avulsion from the superior polar patella. Something is being very different with current days. Is that a view of the other people? Have you also noticed something similar?
Not really. I've
Ajit,
not come
Rajkumar?
across.
Yeah, I can see where you're coming, and I had seen a case, one or two cases with these kind of problem, but more towards like a sort of hematoma collection, then slowly that getting infected and all the tissue getting necrosed, those kind of situations. In an acute this thing, unless there is a traumatic injury, not that very common.
This patient had a history of fall, slip and fall at home, sir, before coming to the OPD.
Oh, okay.
This is a
Yeah,
traumatic.
right. So I think she's lucky that she ended up with you, because most people would have looked at the X-ray and said, it's fine, just go home, brace and go home.
Yeah.
So that's why I think we used to miss a lot of these things before.
Yes,
That's what I was coming to. That and luckily some of them actually healed. But this looks like a last year.
Yes, sir. This is
But
a
a large
4
avulsion.
centimeter. Sir.
It probably will need repair. My only worry is that when you have knee replacements around with already quadriceps which have been cut before and stitched back and now again ruptured, maybe a simple repair won't be enough. Even using anchors, you might need to augment that repair.
So
was that more of a substance tear or was it an avulsion?
So this is a substance tear, sir.
Avulsion,
Substance tear. Yeah. So
this is 3 centimeters proximal to the superior pole of patella, and it was around 4 centimeters in length in vertical direction.
But you still have to bring it back. Your repair, you have to still bring it back to the patella. Just stitching muscle to muscle won't be enough.
Yes, sir. So the treatment options in the literature shows repair alone, repair with augmentation, anchors, synthetic grafts, allografts, and autografts. So the literature has showed that repair alone is never an option because they have high re-rupture rates. So here we have went ahead and got in the same midline incision, we have seen the tear in around 4 centimeters in length. It is extending into the lateral aspect into the vastus lateralis. So we debrided the margins of the tear. We have evacuated the hematoma. We have given a thorough lavage, and we have primary suturing was done using non-observable sutures. Following that, augmentation was done using a quartz poly tape that is 30 into 800 nanometers in length. So the procedure was, we have put a transverse in the inferior. We have passed the quadriceps tape in the inferior pole of the patella and across the patella and superiorly, and in a bundle-shaped manner in the quadriceps tendon, it has been sutured. And this is done in 30 degrees of flexion so that to keep the tightness of the extensor apparatus. And any slacks were removed and tacking sutures were applied to it. So I would go to the second case. So it's a similar scenario, post-trauma in a 1 month earlier bilateral TKR. She presented, she's also obese. She presented with the left side, and pain was present only over the thigh region, no pain over the knee region. So this is the preoperative x-rays, and this is the immediate post-operative x-rays, and this is the presenting. There's no bony injury, component alignment looks satisfactory. And this was a L-shaped tear in the ultrasound. It was seen, and it is a very large tear, around 8 centimeters in length. And it is in the superior patellar region. So vertical limb was present in the vastus lateralis, and there is a horizontal limb is present in the rectus femoris. So along with a collection of 20 cc of hematoma is present. So we have again the same midline incision. As you can see here, there is a vertical tear, but the horizontal tear is not present in the superficial aspect, but it is in the deeper aspect, the horizontal limb of the tear. So if there is no suspicion of there is a horizontal tear, then we would have missed it. But there is a horizontal tear high up in the rectus femoris, way high up. So this was also again primary debridement was done, lavage and hematoma evacuation, and primary suturing was done. Using a quartz poly tape, we have done figure of 8, and this is the final suturing of the quartz poly tape. And this is the extensor apparatus working 0 to 30 degrees. We start immediately. So there is no extensor lag in the patient. This is at post-op day 15. So the post-op protocol included full weight-bearing mobilization from day 0 with brace and walker, and knee range of movement 0 to 30 degrees in the first 2 weeks, and gradually it is increased by 10 degrees each week to achieve 90 degrees of flexion by 8 weeks. So this is just a glimpse of details about the poly tape. Whenever we repair a quadriceps, it has to be augmented so that we can do early mobilization so that we avoid the stiffness in the total knee arthroplasty components. So knee stiffness should be avoided. So ideal material should have high tensile strength for the early mobilization, and no immune reaction, and acts as a scaffold for growth. So polytape possesses all these properties. So there are various mesh available in the market. We have used Neo Ligaments polytape system, and it can be used in combination with allografts or autografts, as Sir mentioned, with the quadriceps tendon or hamstrings. So the timing of surgery, according to Scuderi, has told that we have to suspect for the quadriceps tear, and you have to repair it at the early for the most successful outcomes. Take-home message is extensor mechanism is very rare in the literature, almost up to 0.1 to 1.4% only. So disruption can be suprapatellar, patellar, or intrapatellar. So primary repair has high failure rates, and current treatment protocol always repair should be augmented with allograft or synthetic material or even facial flaps. There is no gold standard method for the fixation of this extensor mechanism reconstruction, sir. Thank you, IAA, sir. I take this opportunity to invite everybody for 4th Smart Conclave in Delhi, sir. Thank you.
Ramnik?
Yeah.
No, the only thing is about this extensor mechanism repair and then mobilization. I don't know. I will prefer a cast for a few weeks in extension, because that I don't think will hinder with your flexion. That is what I feel. So how good is this flexion immediately? Is it that tape allows you like that, or?
Yeah, it's basically the use of this tape actually. So now I was discussing with Rakesh when we were there in Mumbai also. This is the same thing which I was using it earlier to augment our ACLs. Then the company came up with this and we started using it. Now I actually have used it in
Which company gives you this one?
And this is Xeros, XIROS, and this is actually available with one of the MyTech dealers here in Delhi. I can share number. And they first they've also now come up for rotator cuffs and other things. So the best part was that the strength of this material is so good that now I realize that there is no point in me protecting them. And we've had very excellent results in the short-term period itself. And now I think the first patient is nearly a year old. So and flexion is never an issue because this always happens in 2-3 months. So at 2-3 months, they've already achieved whatever flexion they had. Now anything that I augment earlier when I was using the semi-T graft and all those things, definitely this issue was there that you bind them, give them a brace or something, keep them in extension. But I've actually stopped doing it. In last 4 cases or so, I've not given them anything. I've allowed them to do whatever they want to do, and they're very happy.
Okay.
Ramnik, a question. You seem to be seeing a lot of these. Do you think that there's any way the striker implants contributing to something like this?
I've seen it in Smith and Nephew also. I've seen it in Smith and Nephew also. But I probably tell you this, it's a high degree of suspicion. Let me tell you, these cases that this boy has just shown, they were primarily missed in my first room. So all the patients, they go into a first room where the consultants or senior consultants or the fellows are sitting for workup, and they were actually missed. They were told to go, everything looks good, X-ray done, and as someone mentioned, and send them home. But the protocol is they all come to me, and I have realized is that the first thing that is tested is SLR. And if they are able to do SLR and they are told, okay, everything is good, you can go home. I do not do SLR. They are sitting on a wheelchair. I tell them to do knee extensions. So that is the first thing that I see, that they're unable to do it completely. And if I add a high degree of suspicion, if they come with a fall, I tell them put a finger, index finger, that if you have a pain or some problem, and they invariably point. And this L-shaped in lesion that you see, my ultrasound musculoskeletal guy had actually missed it. He had only told us everything looks good, there is some hematoma. I called him up and I told him, no, you have to do it. Either you do an MRI or you repeat your ultrasound. There is something which is you have missed. There is a medial limb, and then the medial limb was found. And intraoperative also, our sports medicine guy who was operating them, he actually missed it. I went in, I told him, no, you lift up your fat belly and look inside, and that is where then they found that thing. So high degree of suspicion in these falls is very important. And patients invariably will tell you. That is why I say, I think earlier also they were happening, but we were missing them and they were healing with fibrosis.
One more thing, whenever there is after 2 months, 3 months, and suddenly there is a hematoma, then there is something going on. If the ultrasound says hematoma is there, but nothing, then we should not hesitate to do an MRI. MRI is definitely one. And one more thing also for youngsters, whenever you see these kind of cases with some suspicion, whenever you have some doubt, always take a true lateral view. A true lateral view, and then compare that in the PAC system with the immediate post-op or the subsequent follow-up X-ray, and you see the level of the patella. You can get a lot of information whether there is an injury to the patellar tendon, avulsion, or superiorly something has happened, the patella has migrated. The moment it has migrated, because these patients sometimes, even with some fractures, they'll be able to do extension or SLRs. So just with the SLRs, we should not go by. And sometimes we should make them to stand. Then they will start buckling. They will not be able to stand. So all those things, it is, as you said, suspicion. And then, in fact, look out for, search for a problem.
Good. Unusual. I have not come across this. Maybe I've missed a few.
Actually, Ratna is working on a paper. We'll have a paper very soon. No, Ratna is working on a paper. We'll have it very soon. In last probably 10, 7, 8, 10 years, we have around 12, 14 patients.
I have 6 cases.
Sorry?
6, 7 cases are there.
So why don't you both join hands?
Yep. But Ramanik has got big numbers, so he will say, let me do it first.
No, the other way around. It's the other way around. Rakesh will say, striker. He will say something else. And then
this I learned today. Striker implants prone for injury.
Yes. Yeah.
So
Rakesh, I want to send them to you. I want to send them to you. You still have IACon there.
No. Don't worry. 2026 IACon, that time they will come. Rakesh will go. And then they'll say, no, ours is quadriceps rupture. 2026.
Recording stopped.
You're getting into dangerous territory. So
I think we can stop sharing now. Yeah.
Yes. Good.
Recording in progress.
Very good.
No, by 26, Ramnik will be a big man.
Right now itself he is a big man. Please.
Now he is not allowed to be a big man. He is big, but he's not allowed. But by 26, he'll be quite big.
I think you have something which I don't know.
Yes,
of course, we know.
No. While we are at it, you give your concluding comments and then we'll discuss all this.
Oh yeah, that's
because this is being recorded.
Oh, you.
No, he stopped recording. I think it said.
No. I started again because the concluding comments are yet to be given.
Thanks, Dr. Ajit, for reminding about this whole concluding thing. I think it was again today the variety of cases. And in fact, from one end to this end, we have seen almost all types of fixations, innovations, how to get away with very limited resources. And but still, good job, reasonably a good job has been done, and patients are benefiting. I think this is shows the youngsters trying to learn and then incorporate in their practice, and more and more of teaching and discussions are happening across the country. I think this is a very good signs and symptoms to take it forward. And I would like to thank the entire presenters, all the presenters who came up with some good cases. I'd like to thank our president, our vice president, Dr. Ramnik, and other faculties for coming and spending time and discussing so that all youngsters benefit out of this. Once again, thank you all.
Thank yourself and Dr. Sanjeev as well.
Yes, yes.
Yes, Sanjeev has been silently keeping quiet.
Is
Sanjeev,
he here? I didn't see his name. Sorry.
Yeah, he's here. Sanjeev, we want to hear from you.
Oh, sorry, I didn't see his name, so I.
No, he's
anyhow,
hiding somewhere.
Oh,
I
okay.
think if you remember from last time, unless until you see him, you don't see him.
I will also request
Unless you look for him, you won't
all
see
the
him.
youngsters who are here to register for the IACon conference in Bhubaneswar, and please do attend the meeting, which is being done only for the delegates, exclusively for the delegates. So it is going to be a feast of live surgeries and then discussions, a lot of good things there.
Cadaveric workshops.
Yeah, cadaveric.
It's a very innovative program. It's a very innovative program from Deva. So people,
Yeah.
youngsters
Quite
definitely
nice,
would,
yeah.
and youngsters definitely will find it
So
different
that
from
is
the
mainly
routine.
to benefit the delegates. Yes. So please, all of you, try to make yourself available. Take some just 2.5 days of time off and then do attend. It's going to be a pure academic program. So welcome you all to IACon Bhubaneswar. And those who have not become members of IAA, please become members by visiting our website, IndianArthroplastyAssociation.com, and to take advantage of all the opportunities available for you guys. Thank you once again. Thank you all.
Recording stopped.
Yep, good.
Right. Now you can say what you want about striker
Dr.
and
Sanjeev Jain
ruptures
is
and
there.
all.
No, I will say something about Didi, not striker.
Didi,
That
oh
kind of
Didi.
statement is nonsense, Dr. Rakesh. Only Kolkata
Absolutely.
can give statements like that.
Welcome her to Delhi. We welcome her to Delhi.
No, she's going to come. Somebody has already filed a case against her today. In Supreme
Crazy.
The Supreme Court, a case has been filed against Didi.
I think she should actually be asked to leave or pushed out or shoved out. She's just people have started people are coming to clinic and saying she's a witch.
Is it? Then there should be something like Bangladesh. The movement should happen like Bangladesh.
Yeah. So a lot of people are saying that if Bangladesh can do it, why can't we?
High time. In fact, one way, even the central government can think about bringing in emergency.
See, that will, if you bring in like a president's rule or something, then that may work to her favor actually.
She'll become a martyr.
She'll become a martyr, and she'll ultimately at a co-election, and she'll go there as a martyr. Like all the sympathy and everything. So I think we should let her dig a bigger, ditch for herself and then fall into it, rather than being kicked out and made a martyr.
She's not even showing any single feeling for the whole incident.
She doesn't have it, so how will she show it?
No remorse, nothing.
No remorse, nothing.
Very bad. That to be.
Imagine she took out a Padyatra against her own self.
Yeah, that's like your
That was
Kejriwal.
crazy.
Remember Kejriwal protesting, sitting, and somebody went and told him, "Say, whom you are the chief minister." Oh, I see. Okay, come, let's go back. He was sitting on the middle of the road and protesting in the middle of the night.
Yes, we want
so she's the same. She's taking a Padyatra, justice justice from whom? Your own government, your own administration, your own teaching staff. And there's this new rumor which has come out that that principal who was sacked is actually her nephew.
High chances. How can
Oh,
it then be not sacked, transferred to another hospital in the same position?
Yeah. So
Then
apparently
high
he's a nephew.
Ramanik, how much is the tape cost?
I think around 12,000 or so. Not much. Around
One pack
Yeah,
is
that's not
12,000.
much. Yeah.
one day, one. So one package, I think, is around 12,000 or so. But
तूने मेरे को
I'll tell
number नहीं
you,
भेजा लेकिन Ramnik.
sorry, I will
length-
just do it right now. I'll do it right
That
now.
length is one pack is sufficient enough. It looks
One pack is sufficient to do a figure
Yeah.
of 8 and then reinforcement.
I can see
I've-
that it was quite long.
And actually, I have used it in one patella tendon as well. And